coming to the next case, this will be a short image-based presentation. So a color fundus photograph of the right eye showing the media is clear, there is no opacity, the disc is normal, the vessels show signs of neovascularization in the end of arcade. So we have to go stepwise, and then we have to come to macula. Macula is showing there are multiple small small hemorrhages that are suggestive of dot and blot hemorrhages. And in periphery RNFL, we can see there in inferior and superior area along with the hemorrhage we are seeing yellow area of ischemia suggestive of cottonwool spot, and in the superior temporal arcade the hemorrhages are showing a central area of clearing that are suggestive of Roth spots. So a diagnosis of diabetic retinopathy, severe NPDR, early PDR is made. Now the FFA of that same person was done, and we can see the FFA is showing a late stage of fundus fluorescein angiogram that shows area of leak from the area corresponding to the area of neovascularization that we have noticed in the color fundus photograph. Similar findings in the left eye also of the same person, and we can see there is an neovascularization of disc additional to all the findings that were present in the right eye, and we are seeing a small subhyaloid hemorrhage that is inferior to the disc, and while presenting we have to say how much away from the disc or away from macula it is. So it is half disc diameter below and half disc diameter temporal to the disc. So the finding, the fundus fluorescein angiogram shows corresponding finding with a blocked fluorescence in the area of hemorrhage. So this is the periphery which shows area of capillary dropouts. So the questions that are commonly asked in the diabetic retinopathy case is what is the prevalence of retinopathy in cases of diabetes? So
see the answer what you have written here is can say the 1 in 25%, 5 years, 60% in 10 years, and 80% in the 15 years. See, basically, when there is a type 1 diabetes, in the type 1 diabetes, the retinopathy is much more than as compared to the type 2 diabetes. Type 1 is more. Secondly, the type 1, you will see the blindness. If you see the blindness in the type 1 out of 4 person in type 1 are blind. 1 out of 4 person in type 1 are blind. If you compare with the type 2, 1 out of 10 person, it is blind in the, you can say, type 2. So type 1 is a blinding disorder that definitely gives, you can say, the very, very important thing. And what we consider today, the India is you can say here the diabetic retinopathy is much more. Here it is happening because of the, you can say, type 1 type of diabetes. And type 2, I think it is on insulin, yes, it is much more in the insulin. Why? Because in the insulin what is happening? It is the, you can say, once you give the insulin, that time, you can say it may be a slow release, or you can say it may be a short time, or you can say 24 hours. But that time it is reducing the sugar. See, the diabetic retinopathy happens not because of the, you can say, more sugar. It happens because of the irregular sugar. It means the sugar which is 100 going 300, 400. If it remains at 160, 180, then you will not get much more type of diabetes. But because of insulin, to remain, now there is a 24/7 insulin has came, so that will see the sugar inside our body, and then it is injected. That is 24-hour sugar is maintained, whatever the number you can say you want. So that is more important than the giving insulin at 2 times or 3 times. Yes, oral hypoglycemic are the better than the insulin. But what happens? The people who are in the diabetes, they never consider their diet. And because they never consider their diet, then they eat the sugar, they eat everything. And I think the diabetologists also not giving much about this trace. They are not giving much trace. They, okay, you eat everything and you increase your dose. So that is problematic. So I think in the, can say in the oral hypoglycemia patient, reversal is possible only in type 2, not in type 1. And so what he has written is very true, that if it is a oral hypoglycemic agent you are taking, the chances of diabetes are late. But when you will have to also see SB1C. If your SB1C is constantly above 8, constantly above 8, then the chances of diabetic retinopathy is much more if it is constantly below 8. So that is also an indicator that you will have to see. Now people are saying that that is not important, but yes, it is important statistically. So here we will have to also see that. So whenever you are maintaining the diabetes, the HB1C is also important. And I think what you have written is correct, in that only thing is that the now we will have to add the constant monitoring of the insulin will definitely help to reduce the diabetic retinopathy.
Yes.
One very valid point, sir, you raised, that is the 24-hour control of blood sugar is important, because fluctuation in blood sugar can also result in breakage of plaques, and that can also be dangerous. So that is what is being emphasized these days,
Yes, sir.
in terms of constant control of blood sugar throughout 24 hours.
Yeah. So, ma'am.
There was a diabetologist who was speaking at a forum, and they have come up with a new thing, because we always consider HB1AC as our parameter, and they have said that that is completely wrong. Though we have no other parameters now, because HbA1c is the average. Like the sugar may be sometimes 50 and sometimes 350. So that is an average. So that itself is also not a correct indicator, because the patient has to be taught, like Lane sir said and Dr. Rajesh Bhai said, that there should be constant, because HbA1c, the patient may get misled into thinking which is the right indicator, which is again very wrong, because that is an average. But at present we have that the only indicator to check our patients.
Yes, ma'am. And we were studying one molecule, that is semaglutide. That is the first molecule that is said to have diabetic retinopathy prevention attached because of the constant blood sugar. So they are studying that, sir. So probably by 1-2 years, that should be the first thing that we should promote in diabetic patients.
And one thing important that now whatever most of those hypoglycemic drugs are having made in a such a way that they maintain the normal blood sugar just to avoid the fluctuation what Professor Lam is saying. Obviously the second generation oral diabetics having a tendency to reduce the blood sugar much, but nowadays third generation hypoglycemics are made in such a way that they have to maintain a constant basis.
Constant blood.
So that there will be no hypoglycemia after taking the drugs.
Correct, Deepak. What Deepak is saying is the third generation drugs, they are coming in the market. Now they are examining, but there are some side effects. Those are happening on kidney. But definitely those drugs are more important. Another thing I want to stress, the people are taking the Ayurvedas and so many medicines, and then in that, I don't know what is the content in that. The diabetes is not controlled, then so many the Karela and non-Karela things are happening. And because of that, the diabetic their diabetes is not controlled, and they are not examining their sugar also. So because of that, the retinopathy is increasing. So we must tell our patient that yes, don't go for all these things. If you want, you can take an addition, but this medicine should be there, so that will help you for prevention of the diabetic retinopathy and also the vision.
Thank you, sir. And the next question will be, it is again a theoretical question. What are the non-diabetic retinopathy related causes of visual loss in patients that have diabetes? And this was the list I could say, but I would like the expert opinion to be added, anything to be added in this list.
You go to the question. What are the non-diabetic retinopathy related causes? Okay, go ahead now. So now amblyopia, ARMD, ischemic optic neuropathy, cataract, glaucoma, hypertensive retinopathy, retinal detachment, and then the other retinal pathologies. Yes, you have written other retinal pathologies, but here you can write ROP. Yes, in the ROP also you can get this. In diabetic you want, sorry, in diabetic I think then you are written.
Sir, like if
everything.
retinitis pigmentosa or something is there, other retinal pathologies.
Yes. You can write down the But those are others.
Yes, sir.
Not in the diabetes.
Yes, sir.
But in the diabetes, yes, the patient is having the retinitis pigmentosa, that can also cause this, or you can say the macular pathologies in this diabetes can also cause. But everything is covered here.
I think the order needs to be changed.
Yes, sir.
The trauma and injury should not come up first, it
Yes,
should
sir.
come up last.
Last, yes, sir.
Like hypertensive retinopathy should come up, then retinal vein occlusion and ischemic optic neuropathy, then hyperviscosity syndrome, because in all these diabetics also there is risk of hyperviscosity, and if there is any further aggravation of hyperviscosity, that can also lead to occlusion and all sorts of things. And then comes your ARMD and glaucoma and retinal detachment and pathologies, whatever.
I kept this question, sir, because I was presenting my case in the final year, my final DNB exam, and my entire mind was I have to focus on diabetic, and suddenly this googly came, and I just froze. I was like, how to think, and then I started blabbering something, and so I thought that when we are presenting a case, still something other than that case can be tied to it and added and asked. Yes, sir.
Thank you, Nilesh.
So, what is the role of PRP in treatment of diabetic retinopathy? So, this is a theoretical question again. Laser is absorbed by RP and the underlying choroid, and for PRP, typically a green laser is used, but other yellow laser and all is also being propagated. Thermal burns denature the tissue protein, which leads to local retinal cell death and coagulative necrosis. By destroying the largely unused or ischemic area, the VEGF production that is from that ischemic area is reduced, and the VEGF load comes down and reduces the neovascularization. So,
what you have written is correct. The PRP, yes, role of PRP is to reduce the neovascularization, also reduce the, you can say the intraocular, this apnavitreous hemorrhage or subretinal hemorrhage. So that reduces in PRP by doing the PRP. But what happens if PRP is not done at the time? See what happens, patient comes late, and because of that PRP may not be done, patient is having the vitreous hemorrhage, then patient has come to you. But another thing is, after doing PRP also, so there is a, you can say the overdoing of the PRP, sometimes you can get the burnout this retina. So this burnout retina is one of the complications which is happening in the PRP. So for that you will have to avoid and do it properly. So doing extra PRP also can cause the, you can say the blindness.
Yeah, that's true. The basic idea is that by PRP, by laser, you want to destroy the part of retina which is ischemic and requiring more and more oxygen, requiring more of growth factor. That's how the growth factor released. So you just want to destroy that and keep the oxygen supply enough for the remaining retina to function, and that's the basic idea.
So the last question will be, what will be the role of anti-VEGF injection in management of PDR? NPDR and DME, it is commonly known. So
Now the when to inject anti-VEGF. So they say if it is a 350 micron, or you can say the edema is there, then you can go for the anti-VEGF. Now there are so many anti-VEGF in the market that we are saying that now another this Hyla has came, then another has came, the another is coming. So many intraocular injections are coming. Basic thing here is how many intra-VEGF injections you are going to give to a patient. So any patient, maybe you can say the rich or you can say poor, and then what happens, always this intravitreal injections, the patient will come to know how many injections you are going to give. I have seen the patient who has received more than 30 injections. So whenever you are thinking of the intravitreal injection, yes, it is needed, should be given 1 to 3 days before surgery. I think here I will not agree, not 3 to 4 days, but 7 days, minimum 7 days before surgery we should give intravitreal injection, and after that you can do. And 15 days within 1 month, once you give the injection, after 7 days till month, that 21 days you can go for the surgery. Then rebleed and I can say definitely it prevent, but we don't know the duration, 1 month, 2 months, 3 months, how much duration it is going to prevent. And then once it is not preventing properly. Here basic thing required is those patients are required into this anti-VEGF. They should be told properly that if you control your diabetes very properly, then the number of injection will definitely reduce. But if you will not control, so it is like an water which is there on the floor. Every time you will mop, again it will come because excretion is defective there. And to avoid that, we are giving the injections. It is going to just absorb the water. So I think there you will have to again advise. And what you have written, only change that 7 days. But everything is correct.
Thank you, sir. Sir, thank you so much, sir. Next, Ekagrita.
Thank you, Nilesh. Next presentation will be by Dr. Ekagrita.